Hello and welcome to this latest podcast. My name's Les Jones. I'm a creative consultant working with Practice Plan, and I'm delighted to say that I'm joined for this podcast with Shiv Pabary, who is an NHS dentist of 40 years standing and is also the chair of the GDPC at the BDA. Welcome, Shiv.
Thank you very much, Liz. Yeah.
It's great to be with you today. We're going to be talking today about NHS dentistry, the future of NHS dentistry. And of course, that's something that's very close to your heart. Just give us a little bit of background about your dental career.
Yeah. So, like I said, I've been in NHS practice for over 40 years. So I worked 20 years in the previous system before 2006 and 20 years since. I'm still in NHS. I still have an NHS practice, and I've worked in the northeast of England, for a long time. So it's something very close to my heart. This is why I do this job, to try and see if there's anything we can do to try and, fix NHS dentistry, like the minister said. Yeah. So that's been my role for the last year and a half.
Obviously, we're talking today about NHS dentistry. Lots and lots of talk, discussion about access to NHS dentistry across the country. What's your sense of the kind of the state that we're currently in?
So it's pretty bad at the moment. Access is not something that's happened overnight. It's been an issue, for the last number of years. It's obviously got worse through the pandemic. It used to be something that was, a bit of pressure within the system, but now access is like fundamentally constrained across the country. And you've heard of dental deserts, where I think a lot of areas now are dental deserts. And to be fair, these stats actually speak for themselves. So 1 in 4 adults is struggling to access NHS dentistry. The EDA estimates the unmet need out there is about 14 million adults. And the irony is, if you look at the number of dentists that are available to work, and the GDC, when we released the figures last week, we've got an increase of about 3.5% on the dental register. So we've got about 48,000 dentists on the register. Now, when I qualified, it was about 20, so we've doubled the workforce. But you still have an access issue. So that tells you something about the system where people aren't willing to work. And if you look at the number that are committed to the NHS in some form, it's actually half of that. And if you look in the whole time, equivalent is about less than 11,000. So that's the story. So we've got, we have dentists, but it's really the system that we work in is not attracting other people to stay.
Yeah. And we all know that the press love a headline, and it seems as though kind of dentistry is creeping onto those front pages more and more with those kind of dental horror stories. Do you think what's being reported in the press is an accurate reflection across the country?
I think so. Yeah, I mean, the stories you hear about people pulling their own teeth out, people going abroad, we've got the statistics on this, and it is true. People can't access, like I said, we've got 14 million adults at the moment trying to ring around, trying to find an NHS dentist. So I don't think it's exaggerated, but I don't think this is something new. I think successive governments have let the profession down. And that is the issue. There's been a lot of rhetoric. So I can remember when the 2006 contract came in, and within a couple of years it was condemned and said it wasn't fit for purpose. And now we have the pilots and the prototypes. Now, one of my practices was, pilots. I've got first-hand experience of that. And, it was Jimmy Steele actually, was the brains behind it. It made sense. But that was abandoned, in 2021. And I think probably for the first time in a long time, we've got a political commitment to try and have a fundamentally reformed contract by the end of this parliament. Now, I think that is really good for the profession. It's an opportunity. Obviously, we're going to have a problem because the minister's repeatedly said that, we've got to work you've got to cut out cloth according to the resources that we have. And that is an issue because you can't reform your way out of a chronically underfunded system. Yeah. We if you want to try and have universal care, you've got to really invest in the service, and you can't expect to, if the government says we've got a fixed amount of money, that'll buy you a fixed amount of dentistry. And I think practices can't be expected to fill that gap up indefinitely.
Yeah. I remember when I first came into dentistry about 15 years ago, all the talk at the time was get prepared. There's a new dental contract coming, is going to arrive any minute now. And here we are 15 years later, and that contract still hasn't arrived. Do you firmly believe that you think that it will happen within this government's tenure?
Well, that's what the minister said, and we're going to hold him to that commitment. I know there's a lot of turmoil going on in the Labour Party at the moment, and I genuinely hope that the current minister and Stephen Kinnock stays in his post, because I think we have a reasonable working relationship within him and his team. If you look at the history of dental ministers between 2021 and 2024, we had 7 dental ministers.
Yeah.
And that doesn't really help. So I think there is some hope. We have started having discussions with the department on the art of possible. But like I said, the elephant in the room is the F word. And unless they have the funding that is necessary to rescue the service, I think it's going to be very difficult.
And let's just kind of explore that for a minute. And as you said, the kind of word coming from the government is, yes, there's reform coming, but we have to work within the existing budgets. There is no more money going to be pumped into dentistry. So it seems that kind of reform is not just going to be in terms of the structure of UDAs or a different way of kind of paying dentists, if you like, for the work they do. But it feels as though the actual structure of NHS dentistry is going to have to change to fit that criteria.
Look, I think the thing is that there isn't a simple answer here. It's a complicated system. If there was a simple answer, we would have done it by now.
Yeah.
And I think, it's got to be a blended approach. And I think most people recognize that, including the department, including the BVA. We need to have a blended contract. So that's the first thing to say. So it's not an easy thing to fix. But I think if you're going to go into fundamental reform, there are some really basic questions that need to be answered. So the first one is, who's the service for? Will be prioritized? What is the NHS dental offer?
Yeah.
How are you going to fund prevention? And I think this is the most important one. I think this is a red line for the PDA, where you've got to align payment to the complexity and the cost of treatment.
Yeah.
So at the moment, we have a buy one get one free system within the UDA, and even with the interim changes that have come in, and I know some commentators refer to the changes that are just coming in April as reform. It's not reform. It's not what the profession have been looking for. It's basically interim changes to the current contract within the same financial envelope.
Yeah.
So I think if we want to move on to fundamental reform, there's some basic questions that government needs to answer. And then what does it want? What does NHS Dentistry stand for? And if you want a universal service, and the BDA have done a lot of work on this, it would cost an extra £1.5 billion, which I know sounds like a lot of money, but in NHS terms, it's money you'd find at the back of a sofa.
Yeah.
It really is like a fraction of the NHS social care budget, which is about 230 billion. So, and if you look at some of the policies from government last year that were reversed, which are the 2-child benefit cap and the winter fuel allowance, and I'm not saying anything about the merits of those policy, but when they were reversed, that cost about 3.75 billion. That is more than the budget for dentistry for the whole year.
Yeah.
So sometimes, you've got to think whether this is about affordability or whether it's about political choice.
Yes.
And that's what government needs to do. We've had a lot of rhetoric, and I think now comes the really hard decisions about, what do we really want to do to support the service? And I think the biggest political risk, in my view, is that you have a government that doesn't make these hard decisions and allows the erosion of NHS dentistry, so that universal access just disappears, not necessarily by design, but really by neglect. So we end up with a system where people think actually it's just an emergency service.
Yeah. But why do you think the consecutive governments have resisted adding extra funding into dentistry? Do you think there actually is some kind of underlying long-term plan to shift the provision to a certain part of the population?
I to be honest, I'm not really sure, because obviously it's not just Labour, it's the Tories as well. Yeah, the last government were the same, and they tried lots of different things like the recovery plan, which didn't really work. But if you look at before 2010, I think the increase every year was about 6% on budget, and then it went to about 1.1%. So in real terms, we've actually lost the funding that dentistry used to have. And maybe they've seen the shift towards private care, and it suits government where, people are choosing to go private. And, I know the Chancellor's ordered an inquiry in the CMA inquiry to private industry, which, we've said as BDA is absolutely perverse to do that at a time when the current system that we have is chronically underfunded. It's really detracting us, taking the attention away from the problems that we have, within dentistry, because I don't think private dentistry is the reason for the NHS crisis. I think it's a rational decision that practices make because they've got no choice. I think it's increasingly the reason that we've got a growth in private dentistry is really as a consequence of the crisis that we have in dentistry.
Yeah. What about morale, Shiv? I mean, you're perfectly placed, aren't you, to kind of to feedback on that. But a lot of the dentists working within NHS that we talk to, that we actually help to make the move to private practice, their morale is kind of rock bottom.
Yeah, so one of the things I've done for the last 30 years is I teach final year students in Newcastle. I've done that for the last 30 years, so that's a job I've done for a long time. And every year when we finish, we have a little lunch thing, and then we always ask them, say, where do you see yourself in 5 years' time? And to a T, I would say most of them don't see a future in the NHS.
Right.
Now, that is a really sad indictment of NHS dentistry, but I think it's even worse for patients.
Yeah.
Because if you look at what's going on in NHS dentistry, you've got chronic funding, underfunding, you've got target-driven system, it's highly regulated, it's financially risky, and then you weigh it up against the private sector where you got autonomy, you can control your costs, you can work the way you've been trained, like the new graduates have, and they just think with their feet.
Yeah.
And so, so it is really a poison brand, NHS dentistry at the moment. But it's not, I don't think it's collapsed. I don't think the industry has collapsed. There are some incredible practices out there who are working really hard within the NHS.
Yeah.
But I think we are at a tipping point. Some people might say we're past that tipping point.
Yeah.
But I think it's my job to try and bring us back. And for those practices that want to stay within the NHS, we've got to have a system that works for patients, because that's what it's all about, but also that it works for the practice.
Yeah.
So that it's rewarding. There's a career for them. And just, it leads me on to tie-ins, which you probably have heard of. And politically, I think, there's a lot of support to have a tie-in a graduate for a number of years after they graduate. And I can see how it makes sense to the politicians and to the public, to be honest, because if you're investing in the training of a dentist, it's quite a lot of money that you're putting in. You want a return on that investment.
Yeah.
But it's not really a brilliant idea if you're trying to handcuff them to a system that doesn't work.
No, it hardly encourages loyalty to kind of stay on if people feel as though they're being forced into a situation.
Yeah. And sadly, I think this is going to happen. I think there's momentum within government for this to happen, as probably next year. And we'll just have to wait and see how that pans out. But I really don't think there's any point in saying to somebody that you're going to be tied in. And especially, I think if it's going to happen next year, you've got people that have made the choice this year.
Yeah.
I think it's unfair on them for a start. But I think if you're going to do something that you want people to stay within the service, they've got to volunteer, like I have for 40 odd years. I've had a good living out of the NHS. It's got to be attractive enough. And we can't go to work to lose money, which is what happens in NHS treatments at the moment, where you have certain treatments that you provide, you're actually losing money providing that treatment.
It really is a kind of an interesting conundrum, isn't it, in terms of how you make that attractive. And one of the things that we are seeing more and more and hearing more and more is about the difficulty in terms of recruitment and retention, and the young people coming into dentistry wanting to kind of make it into private practice perhaps much sooner than they did previously. And we also have lots of reports in the press about the underspend, if you like, of the dental budget, the clawback that the dentists are having to pay. And sometimes those headlines will say, well, you can't have any more money because you're not even spending the money you've got. But of course, there's a different story there, isn't there? And that's not that they're not spending the money, is they just don't have the people to actually deliver the dentistry.
Yeah, and we get that in the discussions that we have with NHS even and the department. That is one of the issues that's, it's been nearly 400 million for the last few years. I know it's dropped to about 36 million this year, which still shows that despite spending the money, and we've got a lot of flexible commissioning, and there's some good ICBs that have spent the money in dentistry, but we still have an issue. Yeah, that shows the funding's not enough. But it's really interesting about the young graduates, if you like. So when I discuss tie-ins with my students, and I say, look, what do you think about being tied in for whatever 3 years to the NHS? And most people do foundation training, and I think it's a good thing. Foundation training is one of the success stories that we've got within dentistry. And then if you make it attractive enough, so it's not a stick and it's a carrot. So maybe there's some loan forgiveness because they have huge loans when they graduate, especially the Plan 2 loans that we have at the moment. And if you give them a career structure so that they have a lot of training, a lot of mentoring while they're there, there's a good recognized pay system for them, it may be attractive for them to stay in the NHS. And I've always said that it's a good place to really look at your teeth, pardon the pun, but it really is, because, the NHS has a very good pension still, I think. I think that's where you really learn a lot of your dentistry. You certainly don't learn a lot of it when you're a student, and some would question whether you're a safe beginner with the, when students graduate. But you really learn a lot in your foundation year, and this can continue beyond foundation year. So I think if you had the structure right and you made it attractive enough for people to stay, they would. I think if you're just saying to somebody, you've got to do your time for 3 years, they'll do their time and they'll leave.
Yeah,
and that's really not fixing the structural issues that we have with the NHS dental contract.
Yeah. Just to pick up on a point that you made a few minutes ago in terms of the momentum, if you like, of NHS dentistry, and we quite often liken it to kind of a roller coaster that it kind of go, once it's got over that particular peak and the movement is downwards, there's a huge amount of effort that is required, just to stop the downward movement in the first place before you can kind of get it back up there. And as more dentists make the move from NHS to private, effectively they're kind of almost accelerating that downward motion, because a private dentist will see fewer patients than an NHS dentist. So therefore, more patients are then kind of put into the situation where they don't have a dentist. Do you think it's possible to stop that downward trajectory and actually get NHS on a firmer footing?
I mean, I had an associate who was very good, and he was an NHS, who was probably about 2-3 years qualified. And I remember him coming to me and saying, look, Shiv, I really have an opportunity to go to a fully private practice. And I remember chatting to him saying, look, are you ready? You feel you can, because the expectations are quite different. And he's been there for the last, 7-8 years. He's been absolutely, happy with that. So I think that the reality is that a mixed practice is here to stay, and private practice is a very important part of dentistry.
Yeah.
If you look at the share of the market that it has, is increasing all the time. So in terms of where the NHS fits in with that, I think what we need to probably accept, and I think government accepts this, the private dentistry has an important role to play, and you draw a line between fully NHS, fully private, and it just depends on your circumstances and where your practice is located, etc., where you are on that line. And I don't think that's ever going to change. I think my job as GDPC chair is for the people that, practices and patients that can't access private care, is to be able to access basic care. Now, we're not talking about implants and Invisalign and all that kind of stuff. We're just talking about giving patients the ability to eat, to smile, and to have no pain.
Yeah.
I don't think that's a lot to ask for, for a population from government. So, yeah, I think in answer to your question, I think you'll still see this up and down. I still think, the dentists of the future will have, hopefully, some NHS commitment if we get the contract right. But I think private practice is here to stay.
Yeah.
And it does subsidize NHS dentistry at the moment.
Yeah.
And that's one of the biggest issues, that it actually, because of the chronic underfunding, you've got to do some private treatments to boost your income, because there's no other way you can increase your income.
Yeah. If I was to kind of pick you up and kind of drop you down in 3 years' time as we're coming to the end of this current parliament, and the government have followed through on their commitment and delivered a reformed contract, what's your sense of what that might look like?
I don't think it'll be perfect.
Mm-hmm.
I don't think it'll be perfect. I don't think we can compare with the private sector anyway.
Mm-hmm.
But I'm hoping that it will, first of all, be sustainable for practices to stay in, so that you don't actually lose money providing NHS treatment. So it's, it's profitable. I'm hoping that it addresses health inequalities, because that is what we're doing. This is what we're here for, is to, make sure that patients that can't afford to access private care have a basic level of care. It's going to be a blended contract. I think if we succeed, I think what we're asking for is capitation. And I think one of the things that's really important in dentistry, which is very different to maybe other health professions, is people like continuity of care with a dentist. I have people come to see me from, a long distances, not because I'm the best dentist, but they're used to see the same dentist, and it's a very personal relationship. So I think capitation gives you that continuity of care. It gives you an avenue to prevention as well, which is really important. I think we need to make sure that the activity payments that we have in the future reflect the cost of delivering that treatment. And that is a must. That's a red line. I don't think my colleagues will stay in a system where you turn up and you do £2 or 300 doctor treatments and you get paid the same.
Yeah.
That just doesn't work anymore. So I think we need to get around how complex care is funded, and then obviously how prevention is funded. And the thing with prevention is with any government is when you're actually investing something into a service, they want to see return on that. And prevention doesn't do that within 5 years. If you have a fluoridation program, which is a really good thing, we're having that in the Northeast. So I think that's a really positive move. And then you have, fluoride varnish, fissure sealants, and, behavior change. That takes time.
Yeah.
And you'll see the results of that probably about 10, 15 years down the road when you don't have the treatment need. And that is how prevention works. So it's very difficult sometimes for government to see this, but you've got to reward that.
Yeah.
So it takes time for you to spend time with you at both for all the prevention as necessary.
Yeah. A lot of talk has gone on over the last, 10, 15 years about a potential move to what's termed a core service. We get the sense that perhaps if any government is going to kind of grasp that nettle and move in that direction, it's going to be this government. The window of opportunity is there. There's a kind of a growing sense, I think, from the public of an understanding that dentistry is going to change, and dentistry can't necessarily be for the whole population. Do you think that opportunity exists, and do you think it's the right direction to travel?
I think some might argue that we have a core service now, right? Got a fixed budget, and you're expected to deliver. Well, the two words they use is everything that's clinically necessary.
Yeah,
and obviously that can't happen. So people argue that we probably have a fixed couch, a fixed amount of dentistry that we deliver.
But there are many. Just to interrupt, there are many people who see an NHS dentistry regularly. I have people within my friendship group who could well afford to go to and pay for private dentistry, but they don't, simply is because that's what they've always done. They've always been to that dentist. They're loyal to that dentist. They like to see that dentist. And it feels as though some kind of legislative move needs to come in to actually force that issue to happen.
And you might be right. Look, I've always said, it depends what you mean by core service. And if you're going to rationally care within dentistry, NHS Dentistry, for the first time since 1948, you've got to think about what that means. Yeah. And like I said, a few minutes ago, the government has to decide, what treatment, what's the NHS offer? What do they want to prioritize? How are we going to fund prevention, etc. Yeah. But if you have a fixed amount of money, you're going to buy a fixed amount of dentistry. And I think my position, and I think the VDA position, is that we don't want to own that. Yeah. It's their contract. And I think I would want government to tell us that actually we can't afford to provide a universal service. What we can afford is, urgent care, treating complex patients. So you either ration care by treatment, so you have a menu of treatments, and you say you can't get no orendo, you can't get crowns at the back, you have a shortened dental arch, and, you can make the arguments clinically. but that's going to increase health inequalities. Or your actual patients. So you turn around, just like you said, but we've got a cohort of patients that are, children, patients of deprived communities, the elderly, where they get a much more comprehensive service, which is what the Nuffield Trust has been saying for a while. Either way, the losers are the patients. Yeah, either way. So yeah, I think we may get to that point, and I'm not sure. We just talk about funding again. I think this is an important point. So when I got elected last year, and I had the meeting with the minister, and I remember saying, look, we are obviously tweaking the contract at the moment. There's some changes coming in, but we need the bigger prize. We need to look at what's there about in terms of fundamental reform, because everybody keeps saying we're going to do that, but at the moment nothing's happened. And we started that process. We started those discussions, and one of the things that kept coming back to us from the department was we've got to wait for the comprehensive spending review, which I think was on the 11th of June last year. So we waited, and guess what? The health and social care budget got the highest. This is when all the ministers go with their begging old Sir Rachel Reeves, the plea for the department. So we got £29 billion for NHS social care. And I thought, brilliant, that's really good news. And then we waited a bit more, and we thought, look, how much of that is going to actually trickle down to dentistry? And I'll let you get the update, but I'll let you guess the answer.
I can pretty easily guess the answer.
So that is the issue. That is the issue. We talk about the rhetoric about how oral health is really important to general health, or it's still seen as a silo.
Yeah.
And as long as that continues, right, we will not fix the system. We need to be part of general health, and they need to put the necessary investment. And it's not a lot of money, like I said, because dentists will always be able to work. We are part of a club where we've been invited, after years of training, and we're the only people with the skill set to do the job. And once you lose a dentist, and I call it lose, but it's not lose, but if somebody moves to the private sector, they never come out.
No, of course.
They never come out to the NHS. So you talked about retention and recruitment.
Yeah.
My aim at the moment is retention. I just want to try and keep what we have at the moment, and then make it attractive enough so that we start to at least part-time recruit some people coming here who commit some of their time to the NHS.
There must be an economic argument for additional investment in dentistry purely on the terms of what that would save from the problems that are created by not invested in dentistry. And we hear, quite often about, the biggest cause of children going into dentistry, into hospital for an operation is because of their poor dental health. So that must be costing the NHS millions and millions of pounds. So there must be an economic argument that says if you invest up front, you'll save this amount further down the line.
And that's a really good example. I mean, that's a classic example, because, all these kids going in having GAs for, unnecessary GAs for teeth that could have been saved.
Yeah.
And, if you look at the cost of that, it's not just the financial cost, it's missing school, having paid, affects the development. And there's all kinds of other, really, adverse effects because of that. But long term, obviously, the supervised toothbrushing scheme, we worked out what if you invest £1 now, you spend you save £3 later. But I think the problem with the NHS, and this is where we need to look at in fundamental reform, is what are you measuring? Because what they do is they pay something within the NHS, and then you've got to measure something. And for the last 40 years since I've been on in fee per item, you were measuring numbers of treatments, of different types of treatments. And even now, we're just measuring activity. We don't look at what, clinical quality is. What is health gain to a patient? So I could talk to you and teach you how to brush your teeth, probably, and talk about diet. But there's no benefits within the system that we have. So all we're doing is saying, here's a pot of money, spend it, and we want to see X amount of activity.
Yeah.
And we're going to move away from that. Yeah. We've got to look into, what prevention means, how you deliver prevention with the skill mix that we had. We want to make sure that, and I understand value for money, and I understand you've got to get a return on your investment. But you've got to start with the right principles and stop measuring the wrong things.
Yes.
If you're going to pay people more to do filling, they'll do a lot more fillings. Yeah. That's the way the system worked in feed, right? So, but we need to look at what clinical quality means and what health gain means, and try and measure different things rather than just activity.
Yeah. A couple of questions to finish. What's your view on dentists' reaction to the changes in the contract in Wales?
So yeah, I mean, I speak to Russell, who's my counterpart there quite often. And the first thing to say is, if you want to negotiate a contract, don't do it like you did in Wales. Yeah, because the way that I think Welsh government, treated the negotiations was poorly. Because they started the negotiation, they stopped, and then they came back with the same deal. And basically, it's a contract that's been imposed, on Wales. So I think the approach was wrong. I've said this to the team that we work within NHS England and department, that I hope that we have a negotiated contract and not one that's imposed. But negotiations where you have your red lines, you have compromises, and then you come to a common solution that works for both. I think Wales is probably in a very difficult place. I think it's probably too early to tell. My reason for looking at Wales is that we need to be careful of what's going on in there, because maybe that's going to form part of the discussions within fundamental reform, like the care packages that they have. And we've got complex care pathways can be reviewed. They're not tried, they're not tested, and I think there's a lot of learning to be done from that before we start looking at whether this could be possible within fundamental reform. So it's not a really good story in Wales at the moment, and I think time will tell.
Yeah. Final question, Shiv. Looking forward, perhaps for the next 4 to 5 years, where are you on the optimism, pessimism continuum for NHS dentistry?
Look, with the job that I do, I've got to be optimistic. The worst thing that can happen is that we just have, like I said, let the service dwindle and disappear, and you'll have like an emergency service. You'll have lack of routine in continuing care. You'll see a lot of avoidable extractions. You'll see a lot of antibiotics being prescribed. But I am an optimist, and I hope that we can have a package that works for patients first, but also for those practices that want to stay within the NHS. It might be a reduced service. We don't really know what it's going to be like. And we've got the 10-year plan that's been announced by government that talks about transformational change, but there's very little detail on that. So I think the ambition is there, the rhetoric is there from government. The challenge really to government is that, put the necessary investment in, if you want to say NHS Dentistry.
Yeah.
So I'm hoping, if you ask me in about 3 years' time, I can say, look, at least we've got a service that's hopefully can stay.
Yeah.
But we'll wait and see.
Well, we'll make that a date for 3 years' time. So Shiv, it's been fascinating talking to you and hearing your thoughts on the future of NHS dentistry. Thanks very much for your time.
Thanks very much.